and it will be just about a lump which is persisting in the breast. The other things we also need to, be not frightened about is we can have these common infections in the breast which could present as a lump in the breast. So you could have a skin infection or a skin tumor which is called as a sebaceous cyst. So this is usually present very superficially on the breast, and usually it just occurs because a hair follicle is blocked, and you have this very obviously an obvious lump in the breast which you can feel. But these lumps are non-cancerous lumps. Then you can also have other lumps like fat lumps. Post any kind of trauma, you could have fat necrosis in the breast, which over a period of time could present with a hard lump in the breast. As we all know, with menstruation we can have changes which happen in the breast, which can present as fibrocystic breast changes, and this can present as a form of a lumpiness in the breast. So the most important thing what we need to know is we need to know how our breasts feel like, and how our breasts will change from month to month as the period progresses. And we need to know what is different in our breast, and uh, be able to identify the new changes. And if it's significant change, that's when we need to get it evaluated from a doctor. So the what are the other common complaints about which what are the other ways breast cancer could probably present? Like I said, the most common complaint is a lump in the breast, which is painless and which is persisting, which is increasing in size. The edges are, not very well defined, and it feels kind of very hard when you touch it. That's the most common complaint. But other than that, you could have other symptoms like you could a lump which is persisting can, or which is something very deep seated. You could just notice that the whole breast feels larger than the opposite side, or the breast could feel red. It can, the skin could be puckered. You can have the pulling of skin inwards, and the skin can appear with dot like an orange peel. It could appear. So those are also other signs, and you could have superficially small nodules on the skin, which also would suggest that it's a cancer. The other symptoms could be the nipple could be retracted towards one direction. Either it could be just pulled inwards, inside, inwards into the breast, and it's not projected out, and which is the normal way it should be, or it could be pulled towards one direction. So all this also could suggest that it's an underlying lump, which is a cancerous lump, which is pulling inwards. Other than this, the breast cancer could also spread to the lymph nodes, that is in the underarm or the axillary area. So you could notice a different lump in the underarm area, which it could also suggest that the breast cancer from the breast has spread to the axilla. But here again, I want to say, not everything you feel in the underarm is a cancer lump. You could just have some especially post pregnancy, or during pregnancy, post pregnancy, during lactation. Many women notice that a new kind of a bulge has appeared in their underarm area. So this will be like a very diffuse bulge or a swelling like thing in the underarm area, and it will feel kind of soft. And maybe once once the lactation has been stopped, it could also shrink to a certain extent, and this is just an additional breast tissue in the underarm. And this is not a cancer lump. It's called an accessory breast tissue, which means that you have uh, um, a little bit of an extra breast in the underarm, and that's all it means. Uh, uh, the other thing which we really need to be aware is most people assume that only if you're in your 50s or 60s you can get cancer, and that is actually not correct. We have women as young as 20 and 23 who have cancer. So every just because you have a lump at a younger age, it does not mean that it could not be a cancer. Like I said, every lump needs to be evaluated, and when we talk about evaluation of a lump, we would include a clinical examination where a breast specialist would feel the lump to see what it feels like and what its characteristics are. And we would also include an imaging technology like a sonomammogram or an ultrasound of the breast to look at how it looks under the ultrasound scan. And if required, we would do a mammogram. And again, if required, then again we would do a biopsy from the lump to confirm what the lump could be. So even younger age with a newly identified lump needs evaluation, and we just cannot assume that just because somebody is in their 20s and this is definitely not a cancerous lump, we can just ignore it, or we can completely let it be and not evaluate it, because we have seen patients who have been misdiagnosed in this way, and the cancer has been allowed to grow in size. And we know that as the stage increases, or as the lump increases in size, the stage of the cancer advances from 1 to 2 to 3 and 4, and the prognosis is obviously more it's different as the stage advances and the prognosis comes down. So our basic idea is to not allow that to happen, because every cancer needs to be diagnosed at a younger age. I mean, at a earlier stage than at a later stage. And that's one of the reasons why mammograms have been advised, why mammograms are suggested above the age of 40. Way before a lump or a cancerous lump becomes palpable, or where you could feel the lump yourself while having a bath or while changing. These lumps, when they're much smaller, would be identified on a mammogram. And on the mammogram, or on the x-ray of the breast, we would be able to identify these really small lumps, which would probably take about 6 months or even up to a year to be picked up on a mammogram. And hence we can identify these lumps and diagnose them at an earlier stage. And that's why mammograms are advised. And usually it is seen that it's very rare that you do a mammogram this year and then you follow it up with another mammogram in a year's time. Very rarely do you identify new cancers in that interval, though it is known to happen, but it is still not very common. And these cancers are usually picked up in stage 1, and they have a much better prognosis. We don't have to, the amount of surgery required is much lesser. We don't have to sacrifice the entire breast. And I think that's one of the plus points. And also the long-term prognosis in the earlier stage is way better compared to later stages. Uh, do anybody have any questions regarding breast cancer?
Only 10 minutes of your cover.
Hmm? Usually when people are diagnosed with cancer, we get various questions like, what are the treatment options we have? Is it going to be only surgery, or is it going to be only injections, or can we treat it with only tablets? And there are a lot of different questions like that. uh, um, every patient needs to be staged before we start treatment. And when we say stage, we need to know exactly how big the tumor was. Had the tumor spread from the breast beyond to the regional lymph nodes? And has there been any distant spread to other organs, a distant spread to, say, liver, lungs, or brain? Or has the cancer spread to bones? So before we start any treatment, we always stage the cancer. And treatment will vary from stage to stage. And also in breast cancer, we always see the subtype of breast cancer. We do something called as the IHC on the tumor to determine the subtype. And so treatment will include hormonal therapy or targeted therapy with HER2 directed therapy, depending on what kind of subtype of breast cancer. Now, coming to surgery, surgery for breast cancer has really moved compared to what was done maybe 100 years back. 100 years back, it was always any breast cancer, the treatment was always just removal of the entire breast. We have now enough evidence to say that we don't really have to sacrifice the entire breast. Most often the breast can be saved. And we can do a breast conserving surgery where we remove only the tumor and retain most of the normal breast. And we can maintain the normal breast with good cosmetic outcomes. And we call that as oncoplastic breast surgery, where we use oncological principles and plastic surgery techniques while the surgery is being done, so that we can get a very good cosmetic outcome. So post surgery, the function and uh, the women feels often much better, because she doesn't have any psychological upsets because of body image issues, and those kind of things are not there. And they can move forward with the treatment, and they don't feel and they don't have this body image issues. So cancer treatment has really advanced. And stage to stage, the treatment will vary, but a component of surgery, chemotherapy, radiation therapy, hormonal therapy, and targeted therapy, these are the most often used modalities to treat cancer. And usually when we treat cancer with a curative intent, all of these modalities would be used in different ways.
Yeah. One question.
So, Ms. Sanjana has a question related to hormonal therapy. Are there any side effects of hormonal therapy? So, hormonal therapy, there are different ways we can give hormonal therapy. It could be in the premenopausal age group. We can have SERMs, which is called as tamoxifen, which could be used, or in the postmenopausal group, we have aromatase inhibitors like letrozole, anastrozole. We can have estrogen antagonists like fulvestrant. So there are different types of hormonal therapy. Yes, each of these tablets have their own side effects, but the benefit of the hormonal therapy, the benefit of these medicines way are much more than the side effects which we would encounter, and hence why hormonal therapy is still advised if the tumor is hormone positive, because these hormonal therapy is very very effective in keeping the cancer under control. And hormone positive cancers are known, to come back after 10 years, 15 years. And now hormonal therapy has even been extended beyond 5 years to up to 7 years in certain subset of patients. Yes, they do have their side effects, and especially for the premenopausal age group, when these tablets are given, we always monitor them to we monitor them every year to make sure they're not having any of the most serious side effects, like increase in the growth in the endometrium of the uterus. So we always do an ultrasound of the uterus. And so every patient on any hormonal therapy would be on follow up, and every visit, pertinent questions related to the side effects would be asked to the patient to make sure that they're not having any of the major side effects associated with hormonal therapy. So among the postmenopausal group for hormonal therapy, these tablets usually can cause a little weakening of the bones. So we also add on therapy to make the bones a little stronger. We add biphosphonate therapy in the form of injections to strengthen the bones. So all medicines have some amount of side effects, but the benefit of the medicine or the benefit of the therapy usually out is way more than the side effects. And if at any point of time we feel the side effects are major or serious, that the therapy would be withdrawn and we would change it.
One to the doctor.
Sanjana has a question, and the question is, how often can relapse happen for breast cancer patient? So relapse in breast cancer is very dependent on the stage of the cancer. It is dependent on the subtype of breast cancer. So like I said, a stage 4 breast cancer, we know with treatment we can control it, but relapse is the norm. They will relapse somewhere down the line. Whereas stage 3 breast cancer, again, we treat it with a curative intent, but in again stage 3 breast cancer, we would look at the subtype of breast cancers, whether it's hormone positive or it's HER2 positive, or is it triple negative. So the hormone positive breast cancers usually have a lesser incidence of relapse compared to the triple negative breast cancers or the HER2 positive breast cancers. And we also know that the hormone positive breast cancers usually tend to relapse later. So usually patients do very well, and maybe 10 years later, 15 years later, or even 20 years later, they could have a relapse. Whereas triple negative breast cancers or the HER2 positive varieties of breast cancers, they tend to have a higher incidence of relapse at a earlier timeline. And usually triple negative breast cancers, we say, can have a higher incidence of relapse within the first 3 years of treatment. And beyond 3 years, then their chances of relapse become as equal to a hormone positive breast cancer. So any breast cancer can relapse, and that's why patients are kept on follow up, and at any point of relapse they will be treated again, and the cancer can be kept under control again. Okay, so Natasha had a question about mastectomy. um, So mastectomy usually for breast cancer, we call it as a modified radical mastectomy, because mastectomy usually just means removal of the entire breast. And So again, mastectomy is usually done when they say the tumor is very big compared to the size of the breast, or you have a smaller sized tumor, but in a very small sized breast, or within the same breast you have different areas where there are different cancers in the same breast, but they, you have 2 or 3 lumps which are not nearby, which are very far away, and hence a mastectomy would be required. So in the mastectomy, you will remove the entire nipple complex, and the entire breast with the fat is removed. So basically you just retain a little bit of the skin with the underlying fat in the area of the breast. And also in mastectomy, we would remove the entire breast, and we would go into the underarm or the axilla, and we would remove the nodes from there, because breast cancer can spread from the breast to the underarm nodes. And here again, the number of nodes we remove would depend on the initial staging, whether the lymph nodes look like they have, the cancer has spread there, or the cancer has not spread. So if the cancer has not spread to the lymph nodes, we would do something called as a sentinel lymph node biopsy, wherein we remove only the lowermost portion of the lymph nodes, and we would send it for testing to see whether the cancer has spread. And if the cancer has not spread, then we wouldn't remove the lymph nodes extensively, or we would not do level 2 or 3 dissection, and we would stop at that. But if the cancer has spread to the lymph nodes, then we would do a little more axillary dissection and remove a little more axillary nodes, or we could do a complete axillary dissection. So for breast cancer, if it's a mastectomy, it's a mastectomy with an axillary nodal sampling, or a sentinel lymph node, or an axillary clearance. But most patients, I would say, would not require mastectomy. A mastectomy, in most patients, we can try to save the breast, or we can conserve the breast. And mastectomy is one option, but for most patients, we can save the breast. And mastectomy would only be warranted in case it is stage 3, or the tumor is very big, or has extensive skin involvement with extensive skin change.
How to prevent that?
So there's one question that says, how to prevent breast cancer? Is it preventable? So breast cancer, I would say 90 to 95% of breast cancers are sporadic, meaning to say they just occur in the person's lifetime, and we really have no idea why it has happened. And only about 5% of breast cancers are hereditary, or it occurs because it's heredited, or it's inherited from the parent. A defective gene is inherited from the parent. So there are risk factors for breast cancer. We say obesity is a risk factor, westernized diet is a risk factor, having had no children is a risk factor, or having children later, not breastfeeding is a risk factor. So all of this, I would say, increases the risk of having breast cancer, but there's really no way we can, say I can do this and this and this, and I could prevent a breast cancer. As of today, we really do not have any of those, except for the hereditary variants of breast cancer, wherein we know there's a lot of clustering of breast, ovarian, or colonic cancer, or pancreatic, or prostatic cancer in the family. And usually these inherited breast cancers or ovarian cancers usually occur at a younger age. So in the cancer patient, we would do a genetic testing to determine whether they have a faulty gene. And if they had a faulty gene, then we would, identify to see whether their siblings or their children have inherited the faulty gene. And there's a 50% chance they could have inherited it from a parent. So only if somebody has a faulty gene would we then think about how to prevent the breast cancer, because in these people who have faulty genes, we could do a prophylactic mastectomy, meaning we before the cancer comes, we remove the breast and we reconstruct the breast, or we do a prophylactic oophorectomy, where we remove the ovaries, because these people also have a higher incidence of having ovarian cancer. So we remove the ovaries, which itself would decrease the risk of breast cancer. So prophylactic removal of the ovaries, removal of the breast with reconstruction of the breast immediately, or we give them the anti-hormonal therapy with raloxifene and tamoxifen, which can also reduce the chance of developing breast cancer. But these methods of preventing breast cancer is only done for somebody who has inherited a faulty gene for breast cancer, like a BRCA gene, BRCA1 or BRCA2 positive breast cancers, and we usually don't recommend these modalities for every other normal individual who has a potential to have breast cancer. But we do know that healthy living, keeping the weight under check, especially in the perimenopausal area, not putting on too much of weight, especially like I said, when you reach menopause, you don't gain too much of weight. Continue to exercise at least 30 minutes per day for at least 4 to 5 days a week, and calorie restriction to a certain extent have been known to help prevent breast cancer. For every breast cancer, Pinky Yadav had a question. Do the lymph nodes in my underarm need to be removed? So initially, when we see a patient, say, and we've diagnosed breast cancer, we would also examine the underarm lymph nodes to see whether the cancer has spread to the underarm lymph nodes. We would do an ultrasound of the breast. We would do an mammogram of the breast, which would also give us further information to see whether these lymph nodes look, enlarged, are they distorted, have their features changed, and do they look like they have cancer. So depending on these features, we would decide, and if any of all of these features suggest that the cancer has spread to the underarm lymph nodes, then they have to be removed at surgery. If these tests suggest that the lymph nodes look normal, and the chance of having it have the chances that it's not probably spread there, or it has not spread yet, we would do something called a sentinel lymph node biopsy, wherein before surgery we take them to the nuclear medicine department and we inject technetium sulfur colloid, and on table we inject methylene blue into the breast, and these two medicines, these dye would migrate from the breast into the underarm to the first level of nodes. So at the point of surgery, we would remove a small portion of these nodes called as a sentinel lymph node, and then we would send them off for testing immediately, called for a frozen section, to determine whether the cancer has spread there or not. If the cancer has spread to these sentinel lymph nodes, then definitely we would be doing a more extensive axillary nodal surgery called as a complete axillary clearance. So lymph nodes have to be addressed at the point of breast cancer surgery, either in the form of sentinel lymph node biopsy or axillary clearance, because that is a part of the staging of breast cancer. And having if the cancer has spread to the lymph nodes, then we know prognostically it is considered worse, and this helps us in determine to what kind of treatment needs to be given post surgery. Sanjana had a question. What should be the duration for examination to stay away from the risk? What I would say is, anybody above the age of 40, we would advise them to do a mammogram every yearly, or at least once in 2 years. In the West, it is advised after the age of 50, but in India, we know that breast cancer occurs a decade earlier compared to breast cancers in the Western countries, and hence here we advise we advise mammograms after the age of 40. So at least yearly, or at least once in 2 years, we would suggest a mammogram for every woman. But anybody less than 40, if they have noticed any lump in the breast or any area of hardness, any spontaneous nipple discharge, any recent retraction of the nipple, or anything different, which is new in your breast, we would advise an immediate checkup, and an immediate checkup at least, to see whether that is something really different which needs warrants further examination. Because according to the Indian data, we've seen that about 48% of breast cancer in about 48% of breast cancer in India is occurring in age groups of less than 50. So for the mammogram, the cutoff is around 40 years of age. But even younger women, if you have to be, what we say is self breast examination, or more than self breast examination, what we say is you have to be aware of what your breasts look like and what your breasts feel like. So basically every month, once your period is over, so what happens is between one period to the other period, there's a lot of hormonal changes, normal hormonal changes which occur in the body, and these changes reflect on the breast. So the breast can feel soft immediately after a period, and as the time progresses, and say just before a period, the breast could feel full, it could feel heavy, and when you feel the breast, it could feel very bumpy or lumpy you could feel. And after the period gets over, again becomes soft, the heaviness decreases, this feeling of bumpiness or lumpiness in the breast also decreases, and that's the time when you examine your breast and you know what your breasts normally feel like. So anything which is different, or anything new, or something feels hard, needs to be examined immediately.
Just not complete.
I want the main take home message for today would be uh, the most often the presenting complaint for breast cancer is a lump in the breast, which is usually painless. And any painless lump in the breast should not be neglected or ignored. And pain in the breast is usually not seen in breast cancer, and pain in the breast usually would suggest a non-cancerous a change in the breast which is happening. But anything new, anything different in the breast needs to be examined, because the earlier we pick up a breast cancer, the better it is. Prognostically, it is better. Thank you.